All right, got
Okay,
it.
perfect. Hi, everyone. Thank you for joining us today for another episode of Pearl's monthly lecture series of 2025. For anyone who is new here, Pearl stands for Focus for Emergency and Acute Care um, in resource limited settings. And we are a nonprofit organization entirely run by volunteers. And we aim to provide free POCUS training to doctors around the world. And the topic of today for the August episode is teaching basic critical care echo in low resource settings. What is the value? Being delivered by one of our very own faculties, Dr. McLean, who is an intensivist based in Newcastle, um, Australia. And Louis currently spending 6 months in the Fiji as well, which is very exciting. So without any further ado, Louis, please take it away.
Thanks, Long. I'm going to try and make sure that this um, talk works well, but if there's any technical difficulties, please forgive me. So this is actually a talk that I gave to the um, uh, World Federation of Ultrasound in Medicine and Australasian Society in Ultrasound in Medicine um, point of care ultrasound in low resource settings webinar series, and I'm going to repeat it here for the Pearls channel. It's really based on a question that I get asked frequently, which is why do you teach basic critical care echocardiography in low resource settings? I've worked in Fiji and taught point of care ultrasound in many Pacific countries. And one of the questions that I get asked when I return to Australia is why do you bother teaching it? So this talk is really just trying to address that question, particularly for people who aren't necessarily working in global health activities, who don't necessarily understand the value, or people who are to sort of help them understand the value. So I'm an intensive care specialist from Newcastle, Australia, as Long said, but I also work for Nepean ICU, and I'm studying through the University of Sydney, and Nepean Intensive Care provides significant amounts of support to Pearls, and we thank them for that. So as I said, the question really is that I'm trying to answer is why teach basic critical care ultrasound here? So this slide shows it shows an intubated patient in intensive care in Tonga. It shows a number of clinicians in Papua New Guinea gathered around a bed. Gathering in a bed around a bed who are looking at get rid of that. Who are looking at somebody who's scanning using a butterfly probe. It's a high dependency unit in northern Papua New Guinea up here. It's the Solomon Islands. It's here in Fiji. A very disparate number of clinical settings, and each with different needs. So why do we teach critical care ultrasound here, and more importantly, critical care echocardiography, which is the focus of this talk? I'm going to try and answer these questions with evidence, as I like to do, and one of the really important answers to the question is that people who get critically ill in these places in low resource settings have a very high risk of dying. So patients who are critically ill and admitted to an intensive care unit in a referral hospital in Western Kenya, for example, and I need to use this data because we don't have a lot of Pacific data in this regard, more than half of those people die. Now, if you compare that to, say, for example, the Australasian setting, Australia and New Zealand, using ANZIC's data, you can see that there is a 8.1% observed in hospital mortality of ICU patients. So much lower rate of mortality overall. So, and these are patients that are critically ill using a sort of non-standard definitions. So what's the difference all about? Well, there's a lot of pieces to the puzzle, but some of the insights come from a very recent study by Tim Baker and the ACIOS study, which is a point prevalence study of critical illness in Africa. Really well conducted study that found that the number of critically ill patients in this low resource setting was very, very large, and 1 in 4 having an infection. So sepsis is the main category of admission. And 1 in 8 being critically ill, with 2/3 of those patients. So 1 in 8 presentations to the hospital being a patient who's critically ill, 2/3 of those patients being kept in a ward bed. And this has some significant implications around the use of point of care ultrasound, the use of critical care echocardiography, in particular for fluid management of these septic patients. And I'll come to a little bit more about that in another slide. So back to the Pacific, you can see that the overall life expectancy for people in the Pacific is lower than we have in Australasia. In particular, Fiji highlighted here because that's where I am at the moment. Average life expectancy of 65, and we've got the top causes of death. Are diseases such as ischemic heart disease, but with communicable diseases still being a fairly significant cause of death. So echocardiography, why does it matter? How does it help? So we've got a bit of data here. There's this study from 2009, one of the earliest sort of studies to show that point of care ultrasound and echocardiography in intensive care can be of assistance. This was done in a high income setting, but found that in more than half of studies, management directly changed. And this has been found in subsequent follow-up studies that when you use point of care ultrasound, you do have findings that result in management changes. Applied to the low resource setting, again, we've got the use of cardiopulmonary ultrasound or point of care ultrasound in a resource limited setting, demonstrating that patients who have, there is a number of findings with point of care ultrasound that are picked up that may not have been picked up clinically, and particularly patients with an underlying cardiac diagnosis, management changes significantly. And those cardiac diagnoses are things like cardiogenic shock, congenital heart disease, or acute valvular disease, all of which, in our context in the Pacific in which we work, are significant medical diseases that occur frequently and that may be not picked up at a clinical examination. So POCUS makes a difference. Certainly when a patient presents critically ill, the use of bedside ultrasound changes the diagnostic certainty and helps you guide resuscitation in terms of fluid management, in terms of inotropes, in terms of definitive management. And this is really what it's all about. So you can see here from this study, a number of different pre-ultrasound diagnoses that were put together from a clinical point of view changed significantly after the application of point-of-care ultrasound. Beg your pardon. And this has been repeated in a number of different studies, unanticipated critical findings on point-of-care ultrasound. Now, this is in septic patients that were thought to be septic. And you can see that 1 in 10 patients had critical findings, so critically changed management in this cohort study of 393 patients in a high-income setting, but unanticipated critical findings about 1 in 20. So, you know, it's not every patient that's going to benefit from point-of-care ultrasound, but it's certainly going to be a lot. And depending on what the prevalence of disease is in where you're practicing, the numbers could be a lot higher than this, recognizing that this is a high income setting. And so, you know, again, with 1 in 4 patients presenting with sepsis, probably in the Pacific, there's a pretty similar amount of patients presenting with concurrent infections and sepsis, and presenting critically ill. These patients have point of care ultrasound, and it changes their management. Now, I think this slide for me shows the absolute dearth of evidence here, which is really just, you know, the issue that we face when advocating for point of care ultrasound and specifically critical care echocardiography. We've got, you know, the overall effect when you look at this meta-analysis seems to be towards benefit, but there's an incredibly high heterogeneity in these studies. Heterogeneity in terms of POCUS application, heterogeneity in terms of fluid management and clinical management changes. And unfortunately, when you look at the RCTs, of which there are very few, the RCTs, you know, the effect seems to cross the null value. When you look at the cohort studies, it seems to be a real effect. And so I think the big issue here is the evidence to actually show that that what we do see in practice is actually occurring. So I'm going to talk through a couple of cases here because this has all been pretty dry so far. Easy ones that I was involved with where management changed based on basic critical care echocardiography. So here, a 25-year-old male who presented with fevers, tachycardia, weight loss, and hypotension. Point of care ultrasound was performed with basic critical care echocardiography performed. And this was the initial findings in the cardiac views. And you can see here we've got the parasternal long axis, we've got the parasternal short axis, and we've got an apical 4 chamber here. Here you can already see you've got a patient who's presenting hypotensive. You've got a large pericardial effusion here, and to be honest, a rather large looking right heart. And this is not playing very well. You can see here that this heart's swinging inside this effusion. So you've got a large effusion, and you do get the suggestion there's some collapse of the right atrium. You've got this patient presenting hypotensive and shocked. This is a diagnosis of tamponade. So how did the management change? Well, the patient rapidly moved towards pericardial drainage, hemodynamic support through that using volume resuscitation. Microbiologic results from this aspiration were important, and consideration of TB serositis was very high on the list of potential diagnoses, and then also for serial examination to see when it was safe to pull the drain out, and whether there was any reaccumulation of fluid. So overall allowed the patient's management to be conducted in a much more sequential fashion. Another case here, a 25-year-old female, fevers, tachycardia, hypotension, abdominal pain, and a missed period. First thing that I would think of as a POCUS practitioner would be doing a FAST scan here to see what the right upper quadrant looks like. But we also do some critical care echocardiography, and you can see here, this loop's not playing very well, apologies. We've got a subcostal view demonstrating again a small pericardial effusion this time. We've got an apical view there, not showing the pericardial effusion as clearly, but showing something on the tricuspid valve here that is independently mobile from the cardiac movements. So an oscillating, independently mobile lesion. You see here with the application of color Doppler that there's essentially a to and fro of the color Doppler indicating what's probably severe tricuspid regurgitation. And this is probably related to infective endocarditis or this agitation on the tricuspid valve. So how did this change management? So the first thing I should say that these basic critical care echocardiography studies were all performed by people who'd done a short course and some online clinical proctoring, and both of them changed management. In this case, it was antibiotic selection, understanding the hemodynamic support around severe tricuspid regurgitation with decongestion that was guided by point of care ultrasound and serial examination in order to manage the strain on the ventricle that occurs in that acute severe TR. And so that's a patient who ended up having being HIV positive, and we are seeing more and more HIV in various places around the world. The incidence of HIV is decreasing, but in places such as Fiji, for example, new infections per year are actually increasing. This is in part to do with increases in injecting drug use. So you can see here in sub-Saharan Africa, where there's a very, very high incidence of HIV, point of care ultrasound has been developed in a way that has allowed focus questions to be answered. And what they've done is put together something called the FASH protocol, which is focus assessment using sonography in HIV, in order to detect things like infective endocarditis, pleural effusions, pericardial effusions, pneumonia, ascites, and other ultrasonographic findings that are hard to elucidate from a clinical point of view, or harder to elucidate from a clinical point of view, that allow you to pick up diseases that may be associated with HIV. So I've talked a little bit about critical care echocardiography and critical care ultrasound, and really there's a number of challenges in low resource settings that we'll talk about. And again, we'll talk about the clinical and systems level value of incorporating critical care ultrasound. And we'll just touch on some training models that we think might work. So there's a hierarchy of there's a lot of terminology, but there's a hierarchy of what we call critical care ultrasounds. There's critical care ultrasound, critical care echocardiography, there's basic critical care ultrasound, there's advanced critical care ultrasound plus or minus transesophageal echocardiography. And this is the case in high-income countries. In high-income countries and in the ultrasonographic literature, these things have all been described in various different forms. So there's FELS, there's focused echocardiography and life support, there's echo-guided life support, there's focused cardiac ultrasound or focused cardiac echocardiography, there's cardiac POCUS, there's critical care echocardiography, there's rapid cardiac assessment, There's all sorts of terminology. What they all really describe is using point of care ultrasound for hemodynamic monitoring and just for phenotyping of various disease states. I do prefer just critical care echocardiography and basic critical care echocardiography to be the way I describe it. So what we teach is 4 separate views, and we've got the parasternal long axis, which is found here. We've got the parasternal short, turn 90 degrees, insonate the heart from a different angle, which is found there. We've got the apical view, which is obviously at the apex. And then we've got the subcostal view, which we insonate using the liver as an acoustic window. We also often add in the IVC, which gives us a look at one of the great vessels and allows us to estimate some right-sided filling pressures. So we learn those 4, we teach those 4 views, and then we put it all together. And we put it all together in a way where we obtain the views, obtain a clinical history, and then put together the views and the clinical history to allow us to phenotype what's going on. And so we'll look for normal or hyperdynamic function, we'll look for impaired LV function, we'll look for impaired RV function. We'll look for a small collapsing IVC, or we'll look for a dilated non-collapsing IVC. And then using that information and the clinical information that we've gained, we'll phenotype the shock into either hypovolemic distributive type shock, cardiogenic, describing LV dysfunction, LV cardiogenic, or obstructive and right-sided dysfunction. Also looking at the pericardium. So what this allows us to do is to phenotype the type of shock and to then tailor therapies. But this is not a hemodynamic monitoring tool per se. So why do well, we know that shock has a very, very high mortality. Critical care ultrasound and critical care echocardiography detects tamponade, massive PE, severe hypovolemia, Guy's fluids and inotropes. It gives you sort of non-invasive real-time decisions. And so when a patient normally comes to hospital, they present with their critical illness, they see a clinician who takes a clinical history and does an exam and comes up with a working diagnosis. They then perform a hemodynamic assessment, looking at the JVP, listening to the heart, looking at the heart rate, looking at the blood pressure, looking at their distal perfusion, and they come up with a hemodynamic state on the basis of that and the clinical working diagnosis. They then might have some pathology identification performed through formal imaging or diagnostic reasoning, biochemical testing. And then based on a response to therapy, you might further elucidate what's going on, looking at the clinical features, response to therapy, biochemical improvements, for example, decongestion in heart failure. And finally, based on the recovery of function, you'll have an assessment of prognosis that gives you your road to recovery. Now, there's lots of different ways and places that this can fall down, and things like not having formal imaging available, not having biochemical analysis available, not having those serial examinations available, the clinical skill, the clinical aptitude of whoever's performing those serial examinations. All these things are areas where this can fall down. So one of the ways that critical care ultrasound can change things, we hope it changes things, is that here you get an early diagnosis with an early hemodynamic assessment. Again, particularly from a cardiac point of view, but also remembering back to patients presenting with septic shock, that a number of those may have unexpected or unanticipated findings. Pathology identification, we're looking at things like ischemia, ischemic heart disease, structural heart disease, much quicker recognized. And then we're looking at guiding therapy response, assessing therapy response, and guiding therapy response using point of care ultrasound as well. Again, much earlier in the piece. Then we're looking at prognostic decision making, and we're looking at prognostic decision making informed by those point of care findings, plus or minus the need surgical or interventional options. And this, ideally leads to a much more rapid recovery and a shorter length of stay, as well as less risk points where this disease with high mortality, shock, is able to progress. It really has a lot of challenges though. In a low resource setting, there's limited primary care, there's limited doctors, especially specialists, specialists who have been trained in critical care or have the ability to perform critical care. There's limited imaging, especially advanced imaging, and there's limited diagnostic testing, such as blood gases, for example. There's also very complex patients, say, for example, congenital heart disease, that may not be recognized until the disease is significantly progressed. And then limited therapeutic options. So, even though a colleague in a low resource setting knows what to do, they don't have the ability to do that. And so these are all big barriers to how useful POCUS can be, but also ideally where POCUS might slot in to help leapfrog some of these issues and diagnostic gaps. So going through shock again, so just thinking about clinical shock defined by low blood pressure, end organ dysfunction. We've got these point of care findings that can identify tamponade, these features, thinking about these disease processes, changing management in this way. LV systolic function, identifying these things on your study, thinking about these different disease courses, changing in management in terms of vasopressor inotrope decongestion. RV dysfunction, severe dysfunction, dilation, septum abnormalities, PA pressure inference, all this can be trained in basic critical care echocardiography with various disease states, both treatable and non-treatable being the causes, and can change the management in terms of vasopressors, inotropes, pulmonary vasodilators, and decongestion. Valve function, severe valve function, again, something that we can train. Severe regurgitant lesions, severe stenotic lesions, and here particularly rheumatic heart disease and adult congenital heart disease, or even pediatric congenital heart disease, unrecognized and progressed, is something that we can pick up and identify. Disease states here, we sort of talked about that, but this can change management significantly, particularly if you're able to access an interventional or surgical approach, which is possible in some of these conditions. Then severe hypovolemia, this is a bit hard to see, but that probably reflects the POCUS findings, because hypovolemia and distributive shock really can essentially have the same point of care ultrasound findings with hyperdynamic LV, small LV diastolic area, and a collapse in IVC. It can be bleeding, it can be dehydration, it can be a distributive shock like sepsis. Again, though, changing therapy. And when you extend point of care ultrasound to a whole of body ultrasound, it can help you with source control, whether that be an empyema, whether it be a cholecystitis, whether it be a pyelonephritis. You can identify these things with point of care ultrasound. So another case here, just to mix things up. This was a 30-year-old female, short of breath, hypoxic with hypotension. And if this phase, you can see there clearly this is patient's got significant mitral stenosis, a diastolic doming of the mitral valve, fused thickened commissures, and a very large left atrium and right ventricle suggests that this is significantly progressed disease with high pulmonary pressures. So those are the findings. Parasternal short axis here, And we can see, I apologize for not playing, but we can see the interatrial septum there, sort of fixed and bowing, which might suggest left pressure. So very much in keeping with a mitral stenosis or stenotic lesion. In the short axis, we can see the mitral valve. You can see that valve's not working very well at all. We can also see a D-shaped septum, which represents pressure and volume overload of the right ventricle. And here that valve's demonstrated a little bit more clearly, even though the cut is still a little bit oblique. And you can see, again, that mitral valve thickening and the commissural fusion. And again, these studies were all done by people who work in low resource settings with limited training courses and online proctoring. You see here in this view, if I can get that to play, you can see here that the right side of the heart's much larger than the left side of the heart, demonstrating what probably represents core pulmonale. There's a couple of specific findings here. The tenting of the tricuspid valve probably represents very, very high pulmonary vascular resistance, subsequent RV dilatation that's pulling the valve apart. Wouldn't be surprised to see significant amount of tricuspid regurgitation there, although that wasn't performed in the case. You can see the RV definitely has reduced contractile function there. IVC is dilated, even though this image is flipped. That equals a very high right atrial pressure. And then you've got lots of B lines in your lung ultrasound that are symmetrical, that probably represent elevated pulmonary capillary wedge or left atrial pressure. So putting that all together, you've got a patient with end-stage mitral valve disease, pulmonary edema, high right-sided filling pressures, significant pulmonary hypertension that's wedge-driven. There are things that you can do to fix this, or at least temporize the patient to try and get them to an interventional or surgical outcome. Managing PA pressures. So this might be some of the management changes that you might do, managing PA pressures, sedation, temperature, vasopressors, inotropes, pulmonary vasodilators. In low resource settings, we don't have the standard things, but something like aminophylline might be used. The really important things, thinking about mechanical ventilation, how the PEEP and the FRC might be manipulated to lower pulmonary pressures, and then blood gases and pH, PaCO2, if you have them, can help you reduce the PA pressures as well by controlling those. And so even just using simple 2D features, we can think about categorizing things like pre-capillary and post-capillary pulmonary hypertension to help guide therapies. So management guidance, we talk about the serial nature of examination helping with this management, and this is exactly where it might work. We'll diurese the patient until we see the IVC collapsing. Then we know we've done enough. We haven't gone too far. We haven't given the pre-renal AKI by going too far. We've done just enough. Once we see the septal flattening improving, then we know that the pressures and the volume overload is improving. Again, this is decongestion guided by echocardiography. The tricuspid regurgitation, this is actually really important to see the tricuspid regurgitation improve, because what that represents is a change in the dilatation of the tricuspid annulus, and reduces the myocardial work because the regurgitant volume is less. And then a simple M-mode measurement to assess TAPSE as a longitudinal measurement of function. You'll be able to see that improve as the RV function improves. So how this changed: hemodynamic support, pulmonary vasodilators, mechanical ventilation adjustments, decongestion with POCUS guidance, and then serial examination. Hopefully I've convinced you by now that this is something that is possible. And so the thing really is to sort of figure out what we need to train. And the use of clinical care echocardiography, it promotes clinical reasoning and allows for a better application of somebody's medical knowledge using POCUS findings. There's different levels of training, and these are levels of training that we use in Australasia. There's Australasian critical care. There's basic, which is essentially a entry-level training. You see there that just demonstrating that phenotyping is the approach. We've got advanced training, so these are people that have been trained or in training in both POCUS and high-end equipment, and they can do a bit more in terms of assessment, fluid responsiveness, grade valvular disease, cardiac output, pressures, possibly procedural. And then we've got expert trained people who are trained in high-end equipment plus everything else. They have formal qualifications and are able to perform advanced cardiac diagnostics. Now, does everyone need to be experts? Probably not. And I think a pyramid really represents the way that the best application of this skill set sits within critical care. And there's often questions asked, particularly in the Australasian setting, as to whether there needs to be an intermediate level that's not quite advanced, but also not quite basic. Here's a couple of slides just to talk about the value of echocardiography and how it sort of scaffolds enhanced echocardiography. And you can see here there's some findings using 2D basic critical care echo that can be supplemented and stretched and advanced with advanced critical care echocardiography. And so, for example, the clinical scenarios such as unexplained shock, those were the 2D findings, trauma, 2D findings again, cardiac arrest, mechanical ventilation, optimizing mechanical ventilation, looking at changes in lung scores with varying PEEPs, and then heart failure management, thinking about what the left atrial pressure is and whatnot. And notice that a lot of the elements here, these are all 2D basic critical care echocardiography, plus a bit of lung ultrasound. But the more you learn, the more you can guide therapy, and there is a lot of value to having Doppler interrogation of, say, for example, left atrial pressure to supplement, and pulmonary pressures to supplement your assessments. Other things that are probably becoming more and more important is Doppler interrogation of visceral organs to assess what the venous excess score is to guide decongestion again. So most of the critical care societies now recognize point of care ultrasound as being a really important part of training. And in this recommendation for core competencies, you can see that the sort of things that we've been talking about for critical care ultrasound have been enshrined in this document. And so assessment of severe hypovolemia, LV failure, RV failure, tamponade, severe abnormalities, assessment of the left and right ventricle and inferior vena cava, as well as thoracic syndrome, which I think do go hand in hand with critical care echocardiography. Cardiopulmonary ultrasound is essentially the way that we approach it and teach it. It's also coming for other specialties, and very soon anyone doing a neuro examination will be supplementing that with point of care ultrasound as well. Going back to the sort of low income countries, low resource settings type of approach, this is the WHO emergency care framework, and you can see here that that there's many links in the chain. How can point of care ultrasound, how can critical care echocardiography change things? Well, ideally, or the way that we are teaching and learning it at the moment is for it to be at the hospital level, where critical care echocardiography is implemented, where it can affect a number of things: the emergency unit assessment, accessing early critical care or early operative care in some cases, and affecting the inpatient stay. And this is the same WHO framework, just with the KPIs. And you can see here that this time to provide a KPI could potentially change, particularly with pre-hospital point of care ultrasound. But more importantly, time to operating theatre and overall length of stay, again, ideally with critical care echocardiography change in management, will be shortened. So where have we trained critical care echocardiography? Well, through Pearls, we've trained point of care echo in Nepal, Botswana, and widely through the Pacific, in Samoa, in Tonga, in Fiji, in the Solomon Islands, in Vanuatu, and in Papua New Guinea. And very interestingly, when we look at the studies and research that have come out of various point of care ultrasound programs, there's very little that's come from the Pacific. This recent scoping review showed that 59% of point of care ultrasound studies and point of care ultrasound studies describing training came from Africa, 23% from Asia. You can see that critical care ultrasound, so cardiac ultrasound in the US, was represented very highly in terms of what was being taught, with at least 50% of courses teaching it. Lung ultrasound also very common, as is FAST, as is OBGYN, particularly in Africa. When this scoping review looked at the different types of training, a lot of what was being delivered was one-off short trainings, some of it repeat, some of it plus on-the-job mentoring, some of it repeat training plus short course with on-the-job mentoring. Very little of it representing longitudinal training. And we know that longitudinal engagement is really important for continuing to enshrine POCUS as part of your practice. So when we put together a POCUS curriculum, a critical care echocardiography curriculum, there's a number of things that we really need to teach at an initial course. So things like anatomy and physiology, theory, knobology, scanning techniques around image acquisition, touching on hemodynamic assessment as part of image interpretation. We also cover how to communicate findings and something like a direct, adopts a competency evaluation, directly observed procedure as part of the delivery of course. Ideally, other things that are delivered as part of a short course is exposure to critically ill patients and clinical integration. And in the courses that we deliver, we try and incorporate that into the time that the course is run, so that the course moves directly into a clinical application. It's also important to recognize that quality assurance programs need to be considered whenever you start implementing a POCUS program. And how much value you get really depends on a number of different things. I spoke a little bit earlier about the prevalence of disease impacting what you will find and what you can do things about. So that's really important to take into account when you're delivering a program and delivering the teaching. The impact of different point of care ultrasound findings is really important, because you want to be teaching point of care ultrasound findings that are impactful and do make a difference, so change management. But you also need to consider the difficulty of these things. And this particularly comes into the advanced critical care echocardiography applications of Doppler, which increase the difficulty in the learning curve. Can it be done though? Yes, it can. There's a number of studies that have demonstrated that even intensivists can learn limited transthoracic echo or focused cardiac ultrasound or basic critical care echocardiography relatively quickly, and the once trained, the acquisition times of these point of care ultrasounds doesn't take a long amount of time, with 10 minutes roughly being the amount of time that it takes to scan a patient and make decisions. So with the critical care echocardiography curriculum, there's a number of different things that do need to go into it. The things that we've integrated in Pearls have been didactic elements, hands-on elements, but also the longitudinal element as we deliver a course and then continue to coach longitudinally to continue the image acquisition, clinical application, and clinical reasoning aspects of the teaching. It's important to have these programs locally led. It's important to have local leaders and champions. And what we build towards is a context-specific, sustainable program that moves learners through the image acquisition phase, to the image interpretation phase, to the clinical integration phase, and become self-sufficient. One of the things that we take into account in all of the training is around what's called a zone of proximal development, which is not teaching people too much, teaching them something that's just outside their area of comfort, allowing them to be comfortable with that before moving them on. And this is part of the longitudinal element. So, the challenges and limitations, there is operator dependence, there is image quality issues, there's imaging difficulties in critically care patients, particularly mechanically ventilated ones. There's time and resource constraints, and then there's the ability to get confirmatory testing, which is often not present. This makes it all quite difficult. And accessibility of the point of care ultrasound infrastructure is also an issue in some places. One of the reasons why what we try to do with Pearls is to use handheld devices that we then donate and allow to be used longitudinally. When we review studies, this is what it looks like. De-identified studies with a little bit of clinical context, and these de-identified studies are uploaded to the cloud using the Butterfly network, and we have various coaches. Many of the coaches are Australasian based, but over the last year, we've developed faculty from Papua New Guinea and the Solomon Islands who have been involved in the Pearls coaching program, and are now, and Vanuatu, who are now coaching learners through their own point of care ultrasound journey. And you can see here, these are from courses delivered in Papua New Guinea and the Solomon Islands and Fiji, where in Vanuatu, where those local champions have been developed. This is supplemented by the high-level users, such as these two internal medicine physicians who came to an advanced echo course in order to continue their training, who are also Pearls coaches, who are involved then in continuing to deliver the program and accessing the higher level confirmatory testing that then in some cases allows us to pursue surgical interventions. So basically that sort of stepping stone along the pathway. So going back to the coaches and how they interface. So this is again how de-identified, how our coaches might interface with the learners. And we can see here we've got one of our coaches from Papua New Guinea and one of our coaches from the Solomon Islands providing feedback to a learner on the image acquisition and the image interpretation and the clinical reasoning aspects around the study. And the Butterfly platform allows us to do this in a longitudinal fashion. The courses are logistically quite complex to run, particularly when you've got a number of different devices that need to be individually managed. But the success of the course depends on the local need and the local engagement and the presence of local champions. And what we've been able to do over this timeline here is to develop that program where we have a number of local champions who continue to assist with the longitudinal learning for basic care echocardiography and more widely point of care ultrasound. In our courses and in the ongoing training, we always make sure that we incorporate pathology from an early point. We integrate the supervision and feedback with the local needs assessments and a point of care ultrasound curriculum. We've managed to perform a number of courses which have resulted in almost 2,000 studies being uploaded. Or is it 17 in-country workshops have been performed and in 9 countries. And what that represents is return visits, which is part of the longitudinal learning, and trained 166 clinicians in 9 countries. So last couple of slides, I just want to talk about the use of point of care ultrasound as a tool for health equity. And I think this is part of the development of local champions, the point of care ultrasound practitioner becoming self-sufficient. And some of the people that we have trained and the faculty that we have developed from Vanuatu he is a remote care practitioner who is wholly self-sufficient with his point of care ultrasound now, and now teaching others, and probably uses point of care ultrasound more than many of the people who have access to more resources. So it's a powerful tool for health equity, because what it allows is the POCUS practitioners to advance their practice, to fill the diagnostic gaps, and also, when relating to the patient, to perhaps improve shared decision-making and diagnostic understanding in a patient group that may have poor health literacy. Because if you can see a picture being shown to you on point of care ultrasound, it certainly makes a lot more sense than being told abstract concepts. That's something that we have noted in our practice in the Pacific countries. So just to sort of demonstrate that none of this happens in isolation, the WHO has enshrined a global mandate for strengthening emergency, critical and operative care, and point of care ultrasound is one of these cross-cutting elements that crosses emergency, critical and operative care and improves care in each of those sections. There is a need for future research to guide many of the questions, such as scoping reviews around the use of critical care in low resource settings, longitudinal evaluation of our programs, various levels of agreement studies between basic versus expert to really define what level of expertise you actually need, and how critical care echocardiography's findings and outcomes affect patients. And as I demonstrated in the slide about looking at the various training studies that have been performed, the majority of point of care ultrasound literature comes from sub-Saharan Africa and Asia, very little from the Pacific. And so this needs to be redressed. Questions that we often ask ourselves are, how do we continue to scale responsibility, the training that we performed, and what does local ownership look like? And I think we're getting closer to having these answers. And one of the final things, just really around teaching and learning basic critical care echocardiography, is how do we make it work properly? and I'm always reminded of this quote from Pinsky and Payen, which is 2005, so 20 years ago, and it hasn't changed, is that no monitoring device can improve patient-centered outcomes unless coupled to a treatment that improves outcome. So hemodynamic monitoring must be considered within the context of proven medical therapies, the success of which is dependent on the clinical condition, pathophysiologic state, and the ability to reverse the identified disease process. Meaning that, particularly with critical care echocardiography, you need to have the ability to identify the pathologic condition, identify the hemodynamic state, and to reverse the disease process in order to make an outcome benefit. And without that, echocardiography is just a monitoring tool without any benefit. And it should be noted that this knowledge state is progressing around the world in critical care as well. So more answers will come. Are there any questions?
Thank you very much, Lewis, for presenting today. It's a very incredibly insightful and comprehensive presentations. I'm just going to briefly stop the recording, and then we can open the floor for everyone to ask questions to Lewis.